how the new treatments are developing, basically. So as we all know, it's a severe form of pediatric encephalopathy syndrome characterized by multiple seizure types. That's the hallmark: multiple seizure types, intellectual disability, and abnormal findings on the EEG, in particular, slow spike and slow wave during wakefulness and sleep, and also the paroxysmal fast activity. These are the hallmark of these like the EEG and essential for the diagnosis. By the ILAE definition, the onset should be before the age of 18 years. We know it's more common in males, and the onset is usually around the age 2. If it is earlier than age 2, then it is more severe form, as we know with any epilepsy disorder. If it is before like the age, younger the age, the more severe the forms. It is rare, estimated to be 1 to 4% of the childhood epilepsy syndromes, and overall like 1 to 2% in the epilepsy world. So what's the etiology? Etiology, about like 20 to 30%, we don't know. After even the extensive workup, we don't find any structural lesion, metabolic abnormalities. And then the other group is the symptomatic. That is the major one. And basically you can say like it's like a roundabout. Any neuropathology can start and end up as being LGS. So what like the Gastaut called, or like most people call it, as like, okay, the different neuropathologies converge to give you the same electroclinical phenotype. And that is like basically the Lennox-Gastaut syndrome's hallmark. Now, if you take individual like the pathologies which I listed, you can see the examples in which the patients may develop the Lennox-Gastaut syndrome. They may develop the epilepsy, or they may not ever develop the epilepsy in their lifetime. So what are the risk factors, or what make them prone to develop LGS in some patients versus the other, is also a work that needs to be elucidated. So the hypothesis is that these, like any neuropathology or the underlying genetic mutation, results in the increased excitatory communication between the interior part of the brain, particularly the frontal lobes of the parietal lobe, and hence they develop a secondary network. And that network is responsible for the electroclinical phenotype. As the work by the Warren showed, like in and also like the functional studies showed, that the hallmark of the LGS, that is the paroxysmal fast activity, slow spike and wave activity, or even the tonic seizures, share the same like network that is being developed and proposed by the pathophysiology. The other mechanisms are decreased interneuron concentrations, or specifically decreased inhibitory synapses, leading to more excitatory the networks. The other is the myelin plasticity, and that plays an important role. So the changes in the myelin, or like more proliferation, can result in promoting the epileptic network generation. So what are the goals for the management of the LGS? I think the goals remains the same for any disease or the epilepsy care for the children. We want to decrease the seizures and their severity. We want to use minimum number of anti-epileptic medications that are maximally effective. We want to improve their quality of life and avoid any complications. I think these are the similar goal for anything. In 2018, LGS Foundation got the caregiver survey, like what the patients who had the LGS, they were getting the treatments. Nevertheless, everybody was on the anti-seizure medications. They had the rescue medication used very judicially, but very few, less than 40%, was receiving neurostimulation with VNS or brain surgery. Only 8% was on getting the dietary treatment. Now, if we look the overall, like our epilepsy patient cohort, only about 1/3 are refractory, 2/3 respond to medications. While it's interesting for the LGS patients, more than 80% are refractory. And hence we are relying heavily on the anti-seizure medication. So that gives us like the room that where work need to be done, or like where is the treatment other than the medications need to be offered to the patients. So these are our traditional anti-seizure medications, and like how we approach our first-line agents are or the sodium valproate and the benzodiazepines, and they are very effective. And then we move to vigabatrin if they have Best syndrome and infantile spasms, or lacosamide. And then the double-blinded randomized controlled trials have shown us a list of a series of the medications that can be used and are effective, including lamotrigine, topiramate, felbamate, zonisamide, etc. I'm not going to go into their details. We all know. I'm focusing more on giving you the overall perspective. And then in the recent years, we have like more addition to these medications, like the cannabidiol that was approved for the LGS and Dravet syndrome. In the initial trial, they showed that the Epidiolex or the cannabidiol was superior to the placebo and can reduce the seizures by up to 40%. And then in the open label extension of these, the drop seizures were reduced by 71%, which is really significant, with the very least number of side effects, sleepiness, diarrhea, or some mild elevation in liver functions, never to the point that they need to be hospitalized or taken care. Rare occasion, yes, it can possible, but not routinely. Plus, the dose is not very higher, and this is an expensive medication. But the commercially available other treatments, like the other formulations that have some degree of THC, basically, that are equally effective and are very judicially used. Fenfluramine is also new in the armamentarium of our treatment for the LGS. It's approved for the Dravet and the LGS. And why everything these days is for Dravet and LGS? Because these are the patients who have tons of daily seizures, very easy to monitor or test and see the response of the medications. So everything is coming out of these two diagnoses. So if we see in their trial period, you can see like these are the drop seizures, and by 15 months, about 50% there was a reduction in the drop seizures, while the non-drop seizures were up to 75% reductions. And when breaking down into different seizure types, they were between 50 to 70%, all seizure types reduced with fenfluramine. It works by modulating the serotonin receptor. I think the side effect or the worrisome point are two things. One, the concomitant use of the medications that can cause the release of the serotonin, so may result in serotonin syndrome. The other is like because they can affect the heart, the valvular heart disease. So an echo before and periodically every 3 months and then every 6 months is recommended. And even after withdrawing the treatment, like a follow-up echo just to see the valvular functions. If the valvular functions are baseline, borderline, then you should be more cautious. Otherwise, good to use. And the dose recommended is very like a small dose. It usually doesn't cause the valvular dysfunction. Rufinamide, it's another adjunctive therapy to LGS. It reduces drop attacks and tonic-clonic seizures, and there are also papers published for like helpful for the tonic seizures too. The side effects are not crazy, only drowsiness, vomiting, and headache. And practically in my own practice, rufinamide is pretty safe, and I use it as like a modern felbamate, which has like a high risk of, like aplastic anemia and hepatotoxicity. Benzyl is my choice before I have the last resort as a felbamate. Switching gear to the non-pharmacological therapy. And I think, as with any patients who have seizure or being like 2 seizures diagnosed with epilepsy, we want to know if there is a lesion in the brain. I think if the patient's even not diagnosed with LGS, and in particular, if there is a diagnosis of the LGS, make sure that we have no focal pathology or no focal lesion, because if that's the case, that should be ideal to resect it. Even if you prove that the seizure looks generalized, everything is generalized, it's a focal pathology. It's more likely the focal pathology that has focal to secondary features developed over time in the development of the LGS. So focal cortical resection early on can improve their neurodevelopment. But if there are uncontrolled seizures, particularly the atonic seizures resulting in multiple falls, injuries, hospital visits, like the emergency room visits, then corpus callosotomy can provide some relief. Now, the choice of the surgeries, and they can be done open surgical, like the transaction. People go anterior to the third of the corpus callosum to avoid the disconnection syndrome, which majority of the population with the LGS, they have intellectual disability and their daily life. I don't think so that they will even feel the effect of, even if they develop the disconnection syndrome. However, as we know, the symptoms of disconnection syndrome are temporary, but in few cases they can be permanent. So if somebody is intact with the or like have a better like intellectual ability, then it should be a caution to offer them, because if they develop, that will decrease their quality of life. Even they will have improved seizure like burden. And then the endoscopic or the laser ablation, both for the focal lesions or like even the corpus callosotomy has been used. Ketogenic diet next. Very simple, high fat, low carbohydrate diet, but not easy to use because it requires strict adherence, monitoring, and then you are preparing an extra meal for one member of the family while the rest some other meal. But nevertheless, it's good alternative to medications. Reduces 50 to 60% of the seizures in patients with LGS. And if that is reduced, it means like less number of anti-seizure medications, less side effects. And the studies that included the patients with the LGS for the efficacy of the ketogenic diet for epilepsy control showed like about 30 to 40% of the seizure reduction at least like after 1 year of the treatment. The study only has one patient and shows like 100%. So it's just like more likely you can say like seeing the overall spirit. Yes, they can provide a good relief, or like 1/3, like the way we divide is like, okay, 1/3 of the patients with the ketogenic diet will respond, like will have significant more than 50% seizure reduction. 1/3 partially respond, between like 0 to 50%, and 1/3 actually get the complications and taken off, or like they don't respond at all. Biggest nerve stimulator, common even in the developing countries, being now used. It's basically, the principle is like you stimulate the left vagus nerve after the branch of the recurrent laryngeal nerve has taken off, so not having any cardiac effects, and then it goes like retrospectively to the brain and changes the catecholamines in the brain to produce the anti-seizure effects. The effect usually is seen by 3 months, or like we give like 9 to 12 months before we call it as like, okay, failure or like not responding. Now, this is a new beast in the town, you can say, the thalamic centromedian nucleus stimulation, and that is basically based on the fact that the thalamus has extensive connections with the cortex. Overlying cortex, and the interior nucleus, which is here like marked as red, you can see has extensive frontal, temporal, and parietal connections. And the blue, that is the centromedian nucleus, has frontal, parietal, and the cerebellar connections. So as we know in the pathophysiology, we talked about that the frontal parietal networks that develop, that is the basis for the LGS phenotype, and using this extensive networking with the connections with the thalamus, the modulation of this region could modify the disease or the presentation of the LGS patients. Now, both of these, the DBS as shown by Fisher, and the RNS as by the Marty Morrell, they are proven efficacious treatments for the epilepsy. DBS has been tried in particular with the LGS patients and showed 40% reduction of seizures in the Estelle trial by Dalek. However, there's no the availability of the RNS for the LGS. There is a feasibility trial going on here in the States to look for the safety and efficacy. We have patients both with the DBS and the RNS placed in the centromedian, but I don't have 1 year data for them to say okay, are they responding or not. However, they are responding for idiopathic generalized epilepsy, the 3-head spike and vein. two out of the three patients are seizure-free. But we have to see for the LGS because they are now have secondary networks, and we have to see how we can modify. This is the RNS cartoon. Sorry, it shows the traditional hippocampal leads, but basically it's flushed with the skull, and they go deep into the thalamus. This is the thalamic electrodes for the DBS, and the DBS device goes into the chest. And there is the DBS trial in the UK called the CADET trial. I think they are doing their pilot feasibility, basically the safety study, and then they will go for the efficacy study as both the RNS and the CADET trial will go. Now, the new seizure medications with like, for example, the mTOR inhibitors, very commonly used now in tuberous sclerosis patients, as it's one of the underlying etiology to develop LGS eventually. The everolimus and sirolimus have been proven adjunctive treatments for patients who have LGS associated with the tuberous sclerosis. So it should be considered early on and should be maintained with the therapeutic range. Okay, now walking towards the future. Okay, what the future holds for us. I think when I started neurology, there was like when I was in Ohio, Dr. Mendel was doing his trial for this like the therapy, like the using the vector to introduce this gene therapy, and we were like, okay, it's in the preliminary stages. The results are there. They're working for the FDA approval, etc. But now we know that there are a number of diseases for which the gene therapy is working. And what they basically are doing is they are attaching a gene that is missing or that is required, attaching it to the viral DNA, using the virus as a vector to introduce or infect deliberately the human cells. And once the viral DNA replicate, the DNA, the gene DNA associated with it also replicates, that they are transcribed to the messenger RNA and translated into the proteins that can restore the lost function. So in adults, hemophilia, thalassemia, and the inherited retinal diseases are treated by the gene therapy. And for the kids, spinal muscular atrophy and the cerebral adrenoleukodystrophy are treated with the gene therapy. Now, for the LGS, that holds a very good promise because we know there are many genetic mutations, for example, KCN1B, SCN8A, SCN12, the underlying, which eventually leads to the development of the LGS. So if we have the gene therapy specific for these genes or products, then I think with the help of the precision medicine, we will be able to help these individuals also. So that's a good, like a future to come for the treatment. Sorry, the stem cell therapy, it's a new avenue. I think we don't have like anything conclusive yet, but so far the results are very promising. Particularly, they have shown like, okay, efficacy in consistent efficacy for the diabetes patients. And these are, you can say, the number of publications, how they took off. I think COVID took a hit in 2020. They are decreased, but they are still significant. I mean, like more than 400 publications in a year. And if you see, like for the neurologically, they can repair the neurological cells. They use the pluripotent stem cells or mesenchymal stem cells to be used. Like in Australia, they are using the umbilical cord, the mesenchymal cells from the umbilical cord, saving them and using them for the respiratory, like the diseases for that individual. So the same like the mesenchymal stem cells or the pluripotent stem cells, that's another debate like which one to use, but they hold promise to restoring the original function by getting to the source cells. I think what need to be elucidated is, okay, what signal they need to promote them to guide those primary cells or the base cells to develop into those you can say the specific targeted cells where we want the cells to function. However, there are like initial work is promising for the Parkinson's disease, multiple sclerosis, stroke, Alzheimer's, spinal cord injury, and there are a few patients. One of my patients is getting it for the epilepsy, but we have to see like, okay, what the response comes out for the epilepsy, but still like another avenue that will come up in future. Precision medicines. Now, in a nutshell, people use personalized medicine or like stratified, like the techniques I think the very baseline precision medicine is the ideal, would be the ideal medical treatment available to everybody if we can do it on a mass scale. It will need a massive AI, artificial intelligence, and the massive data, and how we put the data to include all the racial representations and all presentations from all the sectors, and so that like that can be universal. Because if it is skewed data, then it will help like just like some certain individuals and not the others. So the world of genetics is helping us basically until what we say is like the eyes don't see what the mind doesn't know is the same thing. Like if we need to develop a treatment, we need to know what's the problem. So the disease wise, the genetic studies are now giving us the genetic etiology. If the genetic etiology is known, we can make the animal model, zebrafish model, or the rat model, mice model, and we can then investigate the what is the pathogenic mechanisms. We can identify the biomarkers, the disease biomarkers, and then we can see if the same biomarkers are seen in the humans, and then we can develop the screening tools to diagnose for the disease. Once you have the identify the mechanisms, you can develop the very precise treatment plans. You can test the disease, and you can have new medications, or like more tailored for the, like for example, for the gain of function or loss of function mutations, you will have like different medications to control them. And then if you don't have the genetic, then you do the reverse engineering. You first prove that that mutation can have the pathogenicity, okay, then improve the diagnosis. All these leads to precision medicine. So in a nutshell, precision medicine is basically that you early on recognize, like, okay, what, like the disease, basically by screening them, by stratifying the risk based on their family data or the personal data, or like their lifestyle, and then recognizing early signs of the disease, making an accurate diagnosis. You know, like, okay, where in the pathogenesis the fault is, like defining the molecule, and then defining the gene therapy, or like the ASO therapies, and that is like basically all about the precision medicine. So ultimately, all the research is leading towards the precision medicine. It will take some time, but I think we are walking or maybe running towards that. So this is, I think, one of the very good like the algorithm I found by the Helen Cross and the group for the management of the LGS patients. And basically, this is like they updated their old version, and like gave the new guidelines. So you start with the valproate, add the lamotrigine to it, add refunamide to it. Then you can bring any new medications like cannabidiol. You can produce the clobazam, topiramate, felbamate, fenfluramine, or others, depending on if your patients do. That is good. But once, if you know that, okay, you're going to use this algorithm as the LGS, remember, go back, get the MRI, make sure there is no focal lesion. Because if there is a focal lesion and we can remove that, we may really make a difference in the development of that child. So I think that is the take-home message also. Like while we are working this ladder up in controlling those seizures, then we never neglect to look for the local pathology that can be taken care of. And if that is not, then yes, we can go the ladder, and as the time comes, we can offer them the ketogenic diet. But early on, as soon as they fail, as we know, like most of them will fail. So recognizing the challenges, as I mentioned earlier, like in addition to any in comparison to any patient with epilepsy, where we have 1/3 refractory patients, with LGS, more than 80% of the patients are refractory. They have a very high burden of the side effects, mostly because of the polypharmacy due to us. And it is not like only us. Unfortunately, whenever even the teeny tiny dose of one medication you want to take away, they start having more seizures, and parent says, okay, even he's a little more sleepy, I can't see these many seizures. So you end up adding more and more medications. And because we want to try more medications, we add another one, but then the parents don't want to take it away. But I think that's one important thing is like once you are on 3 medications, if you want to add another one, you have to take one medication off. And that's the only way we can avoid the polypharmacy or the side effects of those, or the long-term side effects, which still we are exploring. They need a multidisciplinary care, neurology, psychology, physical therapy, and other specialties as needed. So in conclusion, I will say it is a challenging condition. It's not easy to manage it. However, like the way the medicine is advancing, we are very hopeful that one day we will have like a better control of seizures in these patients. Now, as I said, the ultimate goal of like the medical advancement these days is towards the precision medicine. So with these, all the innovation and coming the new, like the neurotechnology, like advanced neuromodulation techniques with more than 2 contacts, or you can say like up to 16 contacts, or chronic stimulations of the subdural with 16 electrodes. Those new techniques are coming, and as they are available, we